And we're going to be continuing on talking about some of the stent technology, use of bridging stents, and try and do some of the comparison work that we've done here at Mount Sinai with our different grafts. If I can get my first slide, please. There we go. So we took our 2-year experience looking at fenestrated and parallel grafts and compared them for juxtarenal and suprarenal aneurysms and thoracoabdominals and tried to see, was there really a difference between the two technologies. These are my disclosures. Basically, if you look at the endovascular management, juxtarenal, suprarenal aneurysms, thoracoabdominals, it still remains a challenging cases, especially in those acute cases. The Zenith Fenestrated AAA graft by Cook has been commercially available for several years now, and also we have access to the P branch, which is an off-the-shelf graft, which is still undergoing multi-center clinical phase 2 trial. Thoracic branch grafts that treat juxtarenal aneurysms, thoracoabdominals are limited physician-sponsored IDEs and phase 1 trials. Parallel grafts has also been becoming more popular, and these include the chimneys, the snorkels, periscopes, and sandwich technologies, which we have utilized all these techniques as were illustrated in the cases this morning during the fellows' presentation. Our objective is to assess the outcomes from fenestrated grafts and parallel grafts in the treatment of juxtarenal and suprarenal aneurysms as well as thoracoabdominal in a single center, and evaluate the morbidity, mortality, patency, limb patency, and reintervention rates for the different technologies. This was a retrospective review of a prospectively maintained database, and these were consecutive patients with juxtarenal and suprarenal aneurysms as thoracoabdominal from August 2014 through March of 2017, and we're continuing the database to date. Acute aortic ruptures were not included in the trial. The type of repair was a single surgeon decision based on anatomic and urgency of the repair. Patient demographics, hospital course, etc. were all analyzed. Outcome measures included perioperative mortality, graft patency, reintervention rates, and survival. Obviously, the fenestrated technology was shown very nicely today in our live case, but again, going through fenestrations within the graft that are pre-calculated off 3D reconstructed CT scans, and then created in Australia and shipped to the United States. We used either ICAS or VBX stents as self-expanding, balloon expandable stents, excuse me. Self-expanding stents were used for the SMA, as well as some covered stents depending on protocol. Parallel graft technology is, again, the visceral and renals are integrated, cannulated in an integrated fashion from a subclavian or axillary cut down. And then we've used both balloon expandable and self-expanding stents. And our bias is to put no more than 2 parallel grafts at any one level. And if have to, we'll make multiple sandwich techniques to accommodate 4 or 5 different grafts. And here's an example of a parallel graft, again, where you come in and you have the main graft being coming in. You'll selectively catheterize, in this case, the celiac and SMA, land above the renal, deploy these grafts, then if you need to, move further down and do the renals as the next sandwich graft, thereby putting only 2 grafts at any one level. Here you can see down we've gotten the celiac SMA done, another component being brought down, and then the renal grafts being catheterized from above. If the patient has type B aortic dissection, aneurysms or dissections, we did use spinal drains, and again raising mean arterial pressure between 90 and 100. Patient demographics, 117 complex aortic interventions with 100% technical success. If we look at those patients with the parallel grafts, we had 38 patients of this cohort. The majority of the grafts were placed in the renals, obviously, and then celiac and SMA as shown here. And then for the fenestrated aortic grafts, 32 patients with, again, the majority being in the renals, and then SMA and celiac. If you look at the demographics, they were really very similar between the 2 groups. Their comorbidities were expected hypertension, cigarette use, and then hyperlipidemia coming down, and then coronary disease in about 1/3 of the patients. Freedom from aortic mortality on intervention was no different between the fenestrated groups and those patients with parallel grafts, and showing a slight only 94% versus 97%, p-value of 0.6, carried out to 30-month evaluation. And this really hasn't changed as we continue the analysis, going out now to an additional 18 months. If we look at their overall survival, again, exactly the same as you look at the two different technologies with very similar life table evaluations. Coming down, you look at your perioperative complications. In the parallel graft, we had one episode of bowel ischemia, one wound infection, one brachial hematoma requiring intervention, one myocardial infarction, and one transient paralysis that actually improved with the placement of a spinal drain. In the fenestrated graft, we had, again, similarly, one bowel ischemia, one left lower extremity ischemia requiring common femoral endarterectomy, one iliac limb occlusion, which was treated with thrombectomy, and one perinephric hematoma that required embolization. If you look at graft limb thrombosis of the endografts going to the branch grafts, there's no statistically significant difference between those with fenestrated grafts or parallel grafts with a p-value of 0.5. Those need for reintervention, there's no statistically different, though they're slightly higher in the patients with parallel grafts, but it was not statistically significant. And if you look at the type of reinterventions, again, for those comorbidities, we did have 2 renal stent occlusions, which we were able to go in and salvage, one SMA angioplasty for colonic ischemia, as I mentioned, one iliac occlusion requiring thrombectomy, and then embolization for the perinephric hematoma. And for the parallel grafts, as one anticipated, there was a slightly higher rate of endoleaks, especially gutter endoleaks. We've kind of changed our technology and our technique in doing this, where we tend to use VBXs now for our parallel grafts, and I use a 6 VBX and then flare the distal aspect of the VBX to match the outflow vessel, thereby leaving smaller gutter leaks as you go forward. 2 renal artery thrombosis, again with salvage, 1 celiac thrombosis, 1 renal kink requiring stenting, and the gutter leak embolization in those patients with parallel graft. Intervention-free survival was slightly better in the fenestrated grafts, but not statistically significant, with 74% going out to 3 years compared to 58%. And univariate analysis really shows that no single variable was causal for need for reintervention. And finally, I mentioned earlier, the use of customized vessel stenting as part of the bridging graft. Here's a VBX, which I was bench testing to see its seal. With flare, you can see it's very flexible. You're able to come in and have a significant mobility with the graft as it comes in and still get good seal right at the area of the fenestration. And we looked at that specifically and found that, with those patients undergoing VBX usage, we found, this is early on in the series, but found that they really had excellent results with patencies, technical success of almost 99%, primary patency of 94%, and secondary patency of 100%. Gutter leaks were only one case, so 1.3% incidence of gutter leaks. So really, I think the VBX is a very good bridging stent. I think if I need a stent that has significant more radial force, that's, again, well, I'd go with the life stent or the ICAS stent, but my stent of choice right now is the VBX. So in conclusion, I think parallel and fenestrated grafts are acceptable perioperative mortality for treating juxtrarenal, suprarenal, and thoracoabdominal aneurysms. Parallel branch grafts have acceptable long-term patency rates with low rates of reintervention. The snorkel sandwich technique appears to be viable even for 4-vessel intervention. Obviously, we're looking to see more for off-the-shelf grafts for the fenestrated grafts. And I think staged procedure is critical, especially when treating long segments for thoracoabdominal aneurysms. Thank you very much for your attention.